I thank you all for coming here for this discussion, and I hope it's a forum. I will be speaking maybe for 10 minutes or so, and then the bulk of this will be question and answer. So my name is Dr. Michael Neustein. I am the infectious disease physician here. I also am the chair of the Department of Medicine. And we're going to be talking about Ebola virus, and we really have a great team here at Milford Regional, and I just wanted to introduce our team here. Some, but not everybody is here. There is Kim Knox, who's the infection prevention nurse, who works together very closely with me. There's Donna Ogier, who is the EMT, the head EMT and emergency preparedness in the emergency room. And there's Maureen Harris, who is runs the microbiology lab. And we also have representatives from the fire department, EMT here as well, so we're well represented. Not here is our chair of the emergency room, emergency department, Jeff Hopkins, who has also played a role in our preparedness. So we're going to be talking about Ebola virus, which has been in the news. And this is sort of a picture of the prime suspect we're talking about today. Ebola is a virus. That's the first thing we're going to say. Viruses are one type of infection, one type of infectious agent. Things like influenza are viruses as well. HIV, cold viruses are all viruses. I happen to have studied viruses as well as part of my education. Spent many years studying them. So all viruses sort of behave a certain way. They unfortunately don't respond to the common antibiotics that we use, unlike strep and staph infections. But we'll just get right in and just talk about this virus. And the first thing to do is talk about where the infection is going on right now. And as you can see here is some countries in West Africa. So Sierra Leone, Guinea, and Liberia are three countries really in a corner of Africa, West Africa. These are the three countries where Ebola is currently in an outbreak, epidemic proportions. Other parts of Africa are not involved, and that's important. There were some countries where there were a case or two of Ebola, but these three countries are where the outbreak is out of control right now. These are the three countries that we focus on as part of who we have to be careful about monitoring, where the healthcare workers are going. And Ebola is Africa is a big continent, and we have lots of visitors to different parts of Africa, South Africa and Southern Africa, East Africa, North Africa. Those aren't an issue. It's these three countries. And it is a big outbreak, as we'll talk about, a historically big outbreak in these three countries. And these are sort of up-to-date cases, 13,000 cases. And how many deaths, Kim, do you know?
It was almost 5,000.
5,000 deaths. So, a pretty high mortality, a significant infection in Africa. And in the United States, cases that were unexpected, in other words, not cases that were brought here in a controlled fashion, but cases that we didn't expect, we have 4 cases. And that includes Mr. Duncan, who came from Liberia and went to Dallas. And unfortunately, 2 healthcare providers got infected. So that's 3 cases. And then last week, that 1 physician in New York. So 4 cases of Ebola in our country. And this is a very serious infection, and we've had one death in our country from the Mr. Duncan from Liberia. I think it's important. We have to keep in mind that Ebola is a very dangerous virus, but we're coming into influenza season right now, and that results in, on average, 30,000 deaths a year. So although the vast majority of people who get the flu do fine, a small percentage of people with the flu don't do well, and we certainly have flu cases, lots of flu cases in the hospital. So we're going to be talking about Ebola, but we're not going to lose track of the infections that are here right now. And I just wanted to talk about the history of Ebola, because we know a fair bit about this virus. And this is a figure from the New York Times. The virus first was discovered in 1976, so almost 40 years of knowledge that we have about this virus. And back then there was a pretty big outbreak in the Congo in Central Africa. And there have been a number of other outbreaks in Africa, and they've all been contained. But this is by far the biggest outbreak in Africa right now, in West Africa. These other outbreaks were in rural areas, and people were able to contain the infection, and it didn't spread. This outbreak currently in West Africa is not contained yet. But we do know a lot about this virus. It's been studied pretty well for 40 years. So this is not something that medical science is not aware of and hasn't studied. This is another figure from the New York Times. It's just sort of summarizing the cases that are outside of Africa. And we have that one case in the United States, as we mentioned, of Mr. Duncan going to Dallas, and the unfortunate incident that two the healthcare workers were infected. And these are just the different hospitals that are taking care of Ebola patients in Nebraska, in Atlanta, and Maryland. And then we had that new case just last week. And there have been other hospitals in Europe that are taking care of Ebola patients. And there was one other transmission event occurring outside of Africa in Madrid. So there are only 3 people so far in this epidemic have caught Ebola outside of Africa. 2 in Dallas, 1 in Madrid. So let's talk about some of the symptoms of Ebola. It is, and before we talk about the symptoms, just briefly about how it is transmitted, and we'll come back to this several times. The one thing that makes Ebola somewhat easier to deal with is that the symptom, it's only transmissible. It can only spread when you're ill with the virus. It can't spread when you're not ill from the virus. And that's as opposed to a lot of other infections, including influenza, for example, where you can spread the virus a day or 2 before you're ill. And the symptoms usually occur 2 to 21 days after exposure. 21 days is the longest. Usually it's about 10 days after exposure. And the symptoms, some of them are similar to other viral infections: fever, headache, but then there are pronounced gastrointestinal symptoms: diarrhea, vomiting, stomach pain, unexplained bleeding, muscle pain. And again, this is from the CDC. We're heading up to flu, and how is the flu and influenza different? They're both viruses, but They're spread very different. The flu is spread by air route. Ebola, and it's very common. Ebola is very rare, thankfully. As we mentioned, flu is spread by coughing. Ebola, thankfully, is spread. It's more difficult to spread Ebola. It's really contact with sick people and contact with their bodily fluids, diarrhea, vomit, blood, perhaps to some extent saliva and sweat. Right now, the people who are at risk of getting Ebola are people who are taking care of people with Ebola, either in Africa or in this country. And thankfully, we know who has it in this country. We talked about the symptoms, and a little graphic picture here, but Ebola spreads by infected bodily fluids, and you get diarrhea and vomiting. That's how it's spread. And so just to nail these points down, the CDC has these. Lenny has the poster here as well. And these are some just facts just to nail down. You can't get Ebola virus from the air. And the head of the CDC, the head of DPH, says that if if you're standing 6 feet away from somebody with Ebola, you can't get it. It doesn't get into the air. It's exposure to the bodily fluids. You can't get it through the water. You can't get it through food. You get it from touching bodily secretions from people who are sick. And I think when you think about what's happened in this country, it's useful to think about what happened in Dallas, where Mr. Duncan came from Liberia, was in a house with his girlfriend, many people in the house. They didn't get sick. He was brought to the hospital once, unfortunately not admitted, brought back. The nurses who were taking care of him when he was very sick and had a lot of symptoms like vomiting and diarrhea, they got sick. And this is something as healthcare providers we take very seriously, or anyone who's on the front lines taking care of patients. We're figuring out what we could do to minimize that risk. And but those were the two people who've caught Ebola in this country were dealing with very sick patients. None so far, and it doesn't seem like any of the other, certainly none of the other exposures of Mr. Duncan, and so far, none of the other exposures of the other people with Ebola in this country have gotten the virus. So just to review, transmission only when patients are symptomatic, exposure to infectious bodily fluids. Airborne transmission is basically doesn't occur. And the other thing is Ebola virus is not really stable in the environment for very long. If you have a surface where a few Ebola virus particles land, that virus is not going to be infectious for more than a few hours. Now, if you have fluid, again, blood or gastrointestinal fluids, that fluid is infectious. People who pass away, those bodies are infectious. But surfaces that are not grossly contaminated with fluid are not. Is there a danger of Ebola spreading to the U.S.? This is what the CDC says, since it's not spread by casual contact, unlike the flu or tuberculosis or the cold viruses or unlike those viruses, you have to have close contact. Again, look at Mr. Duncan. It's the people who are directly taking care of him who got infected. So this virus doesn't spread that quickly, particularly in our country where where people have better access to health care, where we have precautions. People who study epidemics think that this is a very dangerous virus. We have to take it very seriously, as we are, and we'll talk about it, how we're preparing for this virus. But if we follow our basic infection prevention rules, it's unlikely that it will spread. So how are we preparing for this? And I will talk and present this material, but this is stuff that Kim Knox and Donna Osier and Maureen Harris have really developed, and Jeff Hopkins, who isn't here. And they'll be available for questions afterwards. We're doing a lot of things. We meet frequently, daily, really, and talk about how we're getting prepared. We're collecting information from all these different agencies. We have a specific plan that we'll talk about, and we're vigilant and will detect this infection early. We've been training, and we'll discuss the precautions that we're using. So, and this is where, we'll begin to talk about how we're responding to this as an institution. First of all, we're all thinking about it, since it is a dangerous virus. Someone comes into our hospital, either through the emergency room, either walking to the emergency room, or taken by an ambulance, or showing up in other parts of our hospital. The first question is, do they have a fever? And, fever above 100.4, and do they have these symptoms? Now, again, Ebola is a fever illness. If you don't have fever and you don't have all these symptoms, or a lot of these symptoms, you don't have Ebola. Now, we're coming up to flu season. And every year, our ER is filled with a lot of people who have fever. So, which of those people could have Ebola? Well, very few of them, because we take a detailed travel exposure history. Anybody who has a fever now in this hospital, we ask, where have you been in the last 21 days? If you haven't been to an area with Ebola, and right now the places where Ebola is being transmitted to other people are 3 countries in West Africa. Or if you happen not to have been taking care of somebody sick with Ebola in this country, because there are a few people here. If those 2 things aren't true, then we could say you don't have Ebola, because we know in this country where it is. The CDC is tracking people who come in from those endemic areas, and I think it's really important, because to think about who we identify as somebody who could potentially have this illness. If you're from Africa and you haven't been back to Africa in 3 weeks, then you're not at risk. And surrounding communities, be it in Worcester or Providence or Woonsocket, there are a fair number of African people who live there. Some of them are from those 3 countries, but if they haven't been back there in 21 days, they're not at risk. And if we had a patient that were to show up, patient comes to our ER, he has a fever, he has body aches, we say, where have you been in the past 21 days? And we have signs out in front of our ER that will show. And if they say they've been to one of those countries, or they've taken care of somebody with Ebola, then we would take additional significant precautions that we'll get into. But again, what the CDC says is that we should have a preparedness plan. We have that. We have a separate area if we were to have a patient suspected of Ebola. We have protocols for using protective equipment. We know to talk to the patient to find out, where they've been. We want to rule out other infections, because right now Ebola is an African disease. People coming back from Africa with fevers, most likely diagnosis is something like malaria, and we want to make sure we rule that out. Things that we don't want to do is put healthcare workers at risk, so everybody uses the right PPE, which stands for the right masks and gowns and protective equipment. We want to take care of the patients. We want to look for other illnesses like malaria, and we're going to minimize additional testing in these cases if we do have a suspected case. And this is sort of the checklist that we have, and this is from the CDC. We have our own customized checklist, and it's important to follow a checklist so we don't miss anything. So this is the sign that we have outside of our ER. So even before somebody comes to our desk, we say, if you've traveled to the countries where Ebola is, and actually this is an older slide, it's no longer in Nigeria or being transmitted in Nigeria or Senegal. You're supposed to let staff know right away. The staff in the emergency room would hand the patients a mask and get them quickly to an isolated area. So this is the sort of plan that we have. EVD is Ebola virus disease. We give them a mask and gloves. We direct them to the area of the emergency room, which is isolated, and the first responders have their own protocols. They'll be asking the right questions as well. If someone calls them from the outside having a fever, they will ask where they've traveled. If it's a concern about contact with an Ebola patient, they will wear the right equipment and let us know before they come in. These are sort of the additional signs that we have in our ER and the log sheet that we would use if there was a suspected case. So this is sort of what it looks like. It's very protective equipment. There are two layers. There is a Tyvek suit, which is a total body suit covering all skin. We have a mask and goggles. We have multiple layers of gloves, and the Donna Ogier and Kim Knox and Maureen Harris have been drilling patients to make sure that you put on the suit correctly and you take it off correctly, because when we're trying to figure out how those two nurses in Dallas caught it, the feeling is that maybe there was some breakdown in the way to wear these totally protective garments. So this requires a lot of practice and hours of practice. Do we think we'll ever have to use this? We're not sure. Hopefully not. But we're drilling our ER and first responders who have any possibility of being exposed to someone sick with Ebola. And so we have contacted the medical staffs, the outpatient clinics, so they know what questions to ask. We've contacted EMS and the fire department, and we have the protocols down. So what are the next steps? Additional training, drilling. You can't be kind of prepared for this. You have to be totally prepared. Again, we don't think that it's going to be likely, but we're as prepared as we can be. We're getting more prepared. This changes day by day where the epidemic is, where it could go, what cases are in the United States. And we're instructing people throughout the hospital. The initial focus was in the emergency room because that's where the most patients would come through. But even outside lab testing, surgery, radiology tests, all these different areas. And if you come into our hospital and you have a fever, or you appear sick, we'll screen for this very rare occurrence, but just to be sure. So I think now I'll invite our three other collaborators here, and we'll take questions.
We've been busy for the last month or two for certain. I think that it's 2, 3, 4 meetings a week. I think we're going Ebola crazy a little bit. It's certainly an experience, but I'd be happy to answer any questions, and I'll introduce Deputy Chief Mark Nelson from Milford Fire.
Good evening. I am Mark Nelson. I'm Deputy Fire Chief for Milford Fire Department. And as Matt explained, we are training constantly on this illness, this virus. My groups, my department had a training today. They had a training yesterday. They have 2 more trainings this week. So it's constant preparation from the dispatchers at the police department all the way through the responders and the private ambulance company that's contracted for the town. So I feel that we're well prepared for this. It's not something that we want to deal with, but it is something that we have to be ready for, and I'm confident that we are ready to deal with this if it happens, within the town borders.
So let me introduce again Donna Oja and Maureen Harris. Donna is our emergency management coordinator, really the guru for organizing all the trainings, pulling all the supplies together, working with outside agencies, with both state and regional and local agencies to make sure that we're as prepared as we can be. And if she has little circles under her eyes, it's because she's had sleepless nights trying to keep up with the updates, to make sure that we have those preparedness plans as up to date as possible. Maureen Harris is our microbiology supervisor. Maureen works closely. We all actually work as a big team. We meet routinely, whether there's Ebola or not. And, Maureen has been responsible for coordinating the efforts that the lab would have. So, Maureen, you might want to describe some of what you've been doing.
In the laboratory, as Dr. Newstein had pointed out, there'll be very minimal testing done on any suspect EVD patient that might present into our emergency department, but we're prepared to help Dawn and Dolph get our first responders all set up with the protective equipment that they need, and in the interim, they'll deliver the care that they need to help the patient get through their crisis that they're in, and they'll be drawing labs, 3 tubes of blood for us. These are all CDC and state mandated recommendations. After the physician in the emergency room is in contact with the state epidemiologist. Those 2 key people will make the risk assessment if we go further with testing on these patients when they present.